We now have Dr. Pandav, who's heading the glaucoma unit at PGI Chandigarh, and he'll be talking about lens extraction alone or combined surgery. What is preferable and more effective? Over to you, Pandav.
Thank you, Vinay, for including it in the program. I have no financial interest in any of the devices that I mentioned. Angle closure glaucoma, you know the pathogenesis. I think we have already briefly alluded to it. The angle closure disease, they tend to have shallow anterior chamber, and as we advance in age, the proportion of angle closure glaucoma also goes up. And what happens is that there's an increase in the lens thickness, and also there's a little change in the position of the lens also happening. That is important. And both these factors combined, they shallow the anterior chamber. And as Vinay said, these eyes, they already have a shallow anterior chamber. And combined, if you look at the combined effect of these two factors, it could lead to shallowing of about 1 millimeter. And that could be very critical in these eyes, because these eyes already have shorter axial length and shallow anterior chamber. So that could be critical in leading to angle closure glaucoma. So the lens plays an important role, and as I mentioned, these two things basically, that the lens position could be a little anterior and the lens is also thicker. So what that results in, clinically we see that as an increased vault, and I think Vinay has already alluded to that how that the vault is actually much bigger, the lens vault in these eyes than if you compare to the normal. So this leads to irido-lenticular contact, and also could lead to pupillary block, and that pupillary block can actually precipitate the angle closure. So there's a reason you do laser iridotomy in these patients, and at least you abolish the angle, the pupillary block component, and that helps. So what is the effect of lens extraction in these eyes? So clinically we have seen, and also Dr. Prateep alluded and actually shown a number of studies and data on this. So there is a substantial reduction in IOP, 2 millimeters, almost 12 millimeters of mercury in these eyes. There's a deepening of the anterior chamber and also opening of the filtration angle. And there's a decrease in the iridocorneal or iridotrabecular contact. And the studies suggest that there's a highest predictive value of initial IOP and the diameter. So if the initial IOP is high, and if the lens diameter is high, then those are the eyes which are going to have maximum benefit of lens extraction. That means the IOP reduction will be higher in those eyes as compared to if these two parameters are less or they are towards normal. So how does lens extraction changes our parameters, the biometrical assessment? So we know the mean IOP, as we mentioned earlier, is significantly lower after cataract extraction in angle closure disease. The angle opening distance, or AOD 500, is significantly higher in these eyes after cataract surgery. And IOP reduction correlates with the increase in the AOD 500 value. So there's a relationship there. And also the lens volume also correlates with the decrease in IOP following cataract surgery. So AOD 500 widening positively correlates with lens volume as well. So that means the removal of the lens from these eyes actually improves all the angle-related parameters that we measure them. And this is kind of a ASOCT demonstration of the same. You can see from A, as we go from A to C, there's a marked increase in the angle width in the eye after removal of the lens, and you can see the anterior chamber depth is increased, and lens vault is practically eliminated. And clinically we see this every time we do a cataract surgery in an eye with a shallow AC, and the next day you see the AC is usually fine, deep, and the pressures are better controlled. So how do we look at the lens extraction versus phacotrabeculectomy? Now, if you have an uncontrolled angle closure glaucoma, I think this study is important, and Prateep also alluded to this. So if you do phaco alone, there will be a decrease in IOP in the postoperative period. However, there will be a certain percentage of cases, probably around 20-25%, who will need glaucoma medications even after surgery, and some of them might even need glaucoma procedure. So even though there's a reduction in IOP following cataract surgery, but that doesn't guarantee that, like it's not universal. Some of these patients, they will still need surgery because they are already advanced glaucoma patients. So phacotrabeculectomy in advanced uncontrolled PSEG, the need for anti-glaucoma medication is significantly reduced, and this is more suitable for non-affording, non-compliant patients, basically. So basically what we are saying is that if you're not able to, if the problem with the follow-up, then better to do a phacotrabeculectomy at least, they will be benefited, for some time. So this is our own data. I think we collected data on 110 eyes. This was published a couple of years ago. And we looked at all our patients where we had done cataract surgery in angle closure glaucoma patients. And we have done for all varieties like PACS, PSC, PSCG eyes. And we looked at the IOP trends on day 1, day 7, and up to 1 year follow-up in these. Follow-up was longer, but at least the inclusion criteria was that at least 1 year follow-up should be completed. And as you can see, the majority of our patients are angle closure glaucoma patient, and about 50%. We have around 20% angle PACS, and PSC were again around somewhere around 30%. So again, majority were PACG patient, and some of them were actually advanced disease, and the mean follow-up were around 3.5 years, 3.5 years. And if you look at the IOP lowering in these eyes, all eyes had IOP lowering following cataract surgery, and also the number of anti-glaucoma medicines needed in the post-operative period were lower than what was needed in the pre-operative period. And as you can see, the PSCs, PSC, PSCG all had lowering IOP, and you can notice that PSCG actually had the maximum benefit in terms of IOP lowering. So PSCG, where we tend to do surgery, some of these patients were actually, we were debating whether we want to do surgery or we want to just to do cataract surgery in these patients. And some of we settled for cataract surgery alone, and that led to a substantial reduce in IOP, as well as the number of glaucoma medicines needed to control intraocular pressure. As you can see, the advanced PSCG, the advanced glaucoma patients, they were also benefited, I think, maximally in these studies. The important thing was that half our patients were of PSCG in the study were advanced, and 11 of them were on systemic drugs, and all were off systemic therapy. They were on oral estrazolamide, and all of them were off oral estrazolamide in the follow-up period. And 6 out of the 55 eyes actually required glaucoma surgery. So their pressure was not controlled with acceptable medical therapy, and they were subjected to surgery. So this figure is just about 11%. And if we had done like the traditional, if we have gone by the usual thinking, then all 50% of these patients, then 100% of these PSCG patients were actually candidates for glaucoma surgery. So, okay, so the lens extraction versus trab. Now, if you look at the another randomized control trial, we have the 50 eyes, I think is already alluded to. Basically, it suggests is that at 2 years follow-up, there was a significant reduction in both the groups, but the trab eyes required fewer drugs. So that means eyes that underwent trabeculectomy had a lower intraocular pressure and lesser requirement for anti-glaucoma drugs. So what about the lens extraction with a combined phaco? That's what we are actually discussing. There's no good study. I looked at a number of studies, and this is a meta-analysis which compares efficacy and safety of the phaco versus phaco-trab in PSCG with coexisting cataract. And once, I think the total number of eyes they could select for this meta-analysis for 460 eyes. So this is a good number, basically. And if you look at this study, this data, the phaco-trab had a greater IOP lowering effect, slightly greater lowering effect, but not actually much difference between the phaco versus phaco-trab. Lower number of anti-glaucoma medicines were required, so there was a significant difference in this group. The phaco-trab eyes needed much lower IOP lowering drugs in the post-operative period. and also the post-operative visual acuity and fields were comparable in both the groups. So lens extraction versus phacotracking, if you look at it, there's a less post-operative complication in the phacoemulsification. Now this is significant, but if you look at the rate of complications, they were much higher in the phacotrabeculaectomy group. So there is a kind of a trade-off. You can get better pressures and less number of medications with phacotrabeculaectomy, but you get more complications in the surgery. So what are the risks of doing cataract surgery? So it looks like that if you do cataract surgery or do combined surgery, more or less they are same. There's a little bit of benefit as well as disadvantage. So I think Dr. Vinay has already mentioned about how to do cataract surgery in these eyes, but technically they are a bit difficult. You may need excessive manipulations. There would be synechia, corneal endothelial issues, and posterior capsule tear is also there, plus other issues are there. So cataract surgery is has its own complications and risk in eyes which are too short. So to summarize, both cataract surgery alone or combined with TRAP are valid options for treating angle closure glaucoma. IOP reduction appears to be marginally better in combined group, but the number of AGM required in the post-operative period is much lower, significantly lower in the combined group. And the number of complications is also significantly higher in the combined group. Thank you very much.